Good evening, all the aspirants present here. So, today's topic is cardiology, and the speaker that we have here is Dr. Manidipta Majumder, ma'am. Aspirants, this is going to be a very interactive session. You can also unmute your mic or you can also type in the chat box. Thank you. Ma'am, you can take over. Thank you.
Good evening, everyone. Welcome to the first session of cardiology part of your MRCP part 1 and part 2 learning and preparation. So I'll just introduce myself. I'm Dr. Manidipta Majumder. I'm an interventional cardiologist. I currently practice in Bangalore. So we'll begin with talking a little about MRCP part 1, part 2, and PACES. Cardiology section will be important for all three of the exams. For MRCP Part 1 and Part 2, there are two papers with 100 MCQs each, as you all know. MRCP Part 1 is more straightforward. These are fast solved MCQs. Won't take much time. It's mostly fact based. And according to the previous records, the pass rate is around 50 to 60%. MRCP Part 2 has a higher pass rate, but I'll come to that. MRCP Part 2, as I understand, is slightly more difficult exam because it has clinical scenario based questions. And these options of the MCQs are more like best of five or best of four options. Not all of the options might be wrong, but there will be one best choice which you'll have to select. The pass rate in MRCP 2 is around 60 to 70%, which is very good, but that is mostly because many of the part aspirants they cross MRCP part 1 and never sit for part 2. And as you know, PACES is probably the most difficult of the all three exams of MRCP, which has 5 stations and 8 interactions, and it will involve a lot of cardiology work and learning and examination skills and all. So, without much further ado, I'll proceed. If you have any questions about the pattern and everything, please feel free to ask me. Not much has changed in MRCP 1 and 2. A lot has changed in PACES. So, today's objectives are we'll review the cardiac anatomy and embryology, learn about cardiac physiology, that is, cardiac cycle, heart sounds, and murmurs, discuss some common valvular and congenital lesions, and apply knowledge with MCQs and clinical scenarios. So, I'll begin with a question, and I will really like everyone to be very interactive. You can answer anything, even if it is wrong, it's fine. This is just a discussion. The first question is: a patient with long-standing mitral stenosis presents with progressive dysphagia. Which structure is mostly enlarged to cause this symptom? Would anyone care to answer? You can unmute yourself and answer.
Yeah, left atrium.
Left atrium. Yeah, that is the correct answer. Hello? Yes? Hello, I'm hearing some noise. If there is a discussion, I'll appreciate if people talk one by one. Just give me a moment. The laptop is stuck. Mm, mm. Yeah, so the answer is indeed left atrium. The left atrium enlarges and presses posteriorly over the esophagus. And there is dysphagia while swallowing. So coming to the gross anatomy of heart, borders of the heart, as you all know, I have kept a X-ray on the side. This is a normal X-ray of a completely normal individual because most of these border questions they come in reference to the X-ray. Right border is formed mainly by the right atrium here, and some part is formed by the SVC above and IVC below. So on chest X-ray, it runs from third to sixth costal cartilages. Third to sixth costal cartilages. If it is larger than that, if it like occupies a larger area, then there is a suspicion of right atrial enlargement. Left border, this border is formed mainly by the left ventricle. It extends from the second costal cartilage to the apex. On chest X-ray, forms the main left cardiac contour. What are the other structures that form? That is the aortic knuckle, then the pulmonary bay, which is a concave area, normally concave or straight area, and then the left atrial appendage, and then the left ventricle. These are the four things that forms the left border of the heart. Okay, so this left auricle, we don't call it auricle anymore, we call it left atrial appendage. So inferior diaphragmatic border is formed by right ventricle majorly and by left ventricle partially in the apical side. It rests on the central tendon of the diaphragm, and superior border is formed by the right and left atria with auricles projecting forward. Surfaces of the heart and relations, this we need to remember any of the symptoms that this valvular heart disease or chamber enlargement produce. So anterior sternocostal surface is formed mainly by the right ventricle, and hence clinically when we take lateral x-rays, then this space between the sternum and the heart, when it is obliterated, we call it right ventricular enlargement. Inferior diaphragmatic surface is formed by the left ventricle in 2/3 and right ventricle by 1/3, rest on the central tendon as told earlier as well. Left or the pulmonary surface is formed mainly by the left ventricle related to the left lung and the pleura. Right pulmonary surface formed by the right atrium related to right lung and pleura. And posterior surface or the base is formed by the left atrium majorly, here the left atrium majorly, and part of right atrium, receives pulmonary veins and SVC and IVC related posteriorly to the esophagus. Here we can see in this diagram is related to the esophagus, the descending thoracic aorta, the thoracic vertebra from T5 to T8. So all these structures can be affected with a left atrial enlargement. The posterior surface of the left atrium, the pulmonary veins, all these are extrapericardial structures. The rest of the heart is enclosed in the pericardium. So this is the gross anatomy. This is how the heart actually looks. It's quite a healthy heart. So you can see the auricles are projecting. Usually the atrium do not form the borders. The auricles do. This is right atrial appendage. These are the pulmonary artery. The pulmonary artery lies anterior, and hence any turbulence of flow in the pulmonary artery is better heard than the aortic sounds. And any normal increase in flow in the pulmonary arteries will also produce murmur, even though there may not be any disease, like in young children, in hyperdynamic states. So this is the left ventricle, right ventricle, infundibulum. These are the grooves, right AV groove. These are the acute margin. This is the anterior interventricular groove. We'll come to the structures that run through there. I'm sure all of you already know. It's just a recapitulation. This is the ascending aorta, and this is the pulmonary artery related in a twisted way. Why is it so? We'll come to the embryology part as well. I will be skipping the normal movement of the blood through the heart. I hope everybody knows it. Blood comes from the two systemic veins, SVC and IVC, and drains into the right atrium, which again drains the blood into the right ventricle. In between, we have the tricuspid valve, which has three cusps and lots of chorditendinae, which attaches to the papillary muscles in the wall of the right ventricle. And this blood again goes through the pulmonary valve into the main pulmonary trunk, which divides into the right and the left main pulmonary arteries, and which further divides into branches. This pulmonary valve is a semilunar valve. And again, one point to mention is tricuspid valve is the largest valve of the body, and pulmonary valve is the smallest valve of the body. And from the lungs, the oxygenated blood will come to the left atrium through the four pulmonary veins, two superior, two inferior pulmonary veins, and then go into the left ventricle via the mitral valve. Mitral valve is a bicuspid valve with an anterior and posterior cusp. Again, has many chorditendinae and papillary muscles. Two papillary muscles here, three papillary muscles here. Uh, uh, and from this blood again goes through the aortic valve into the into the ascending aorta, into the arch of aorta, and these are the arch branches. Can anyone tell me about the arch branches? What are the arch branches? Am I audible? here the arch branches are not named. Can anybody tell me what are the branches, the blood vessels that come out of the aortic arch traditionally? Yeah,
Left main, left main coronary artery from the aortic sinus.
yeah, from the sinus, the coronary arteries come out, and then these three, the ones I'm pointing at with my arrow, what arch branches? Yes, one of you speak, please.
Subclavian artery,
Yeah, this is the which subclavian artery comes out from the arch?
left one.
Left.
The left one. So this one, left subclavian. Then this one is
Left carotid probably.
yes, left common carotid. Huh? Be very
Left. Yeah.
specific. Left common carotid, and this one is a
This
brachiocephalic trunk.
breaker. Yeah.
Yeah, which divides again into the right common carotid upwards and the right subclavian artery, right? So this is the gross anatomy of the four chambers. Again, I'm sure you all know, but I would like to mention some of the points, some of the MCQ points that usually comes. This is we have opened into the right atrium. So what is labeled here? The SA node, the sinoatrial node. The sinoatrial node is present traditionally at the junction of the drainage of the SVC into the RA on a crest. Can you see this is a bulging part? Huh? On
Yeah.
this,
Yeah. We can see. Yeah.
yeah, on this part, the SA node is there. It is mostly epicardial in location, whereas the AV node is endocardial in location. Okay. And this is the fossa ovalis, which is the remnant of the foramen ovale, right? Which closes during the birth. There is physiological closure followed by the anatomical closure. So there is a smooth part, as you can see here, and there is a rugged part, rigged part. These muscles are called pectinate muscles. And this is the terminal crest or crista terminalis. So this, when it goes there, this is a whole crest which forms. So SA node is just beside that at the entry point of the SVC in the epicardial surface of the right atrium. Okay. What are these? These are two valves. One is protecting the mouth of the IVC. This is called the eustachian valve. And this valve, here there is a small vein that goes inside. This is the main vein of the venous drainage of the heart, which is called the coronary sinus. Coronary sinus is lined by one valve. What is the name of the valve? Can anybody say? Is a Thebesian valve. Okay. And this is the tricuspid annulus, we can see, right? So pectinate muscle, crista terminalis, right atrial appendage, SA node, SVC entry, IVC entry, fossa ovalis, and eustachian valve, Thebesian valve, and coronary sinus entry. These are the important landmarks of the right atrium. This is the left atrium. Not many questions come from here, but there are four openings of the pulmonary veins. These are the superior ones, these are inferior ones, these are the right ones, these are the left ones. Why are these important? These are important clinically because one procedure is done around these veins. Can anybody tell what kind of procedure is done? Yeah, it is called pulmonary vein isolation. Pulmonary vein isolation is done for atrial fibrillation. Okay, in patients who in whom anticoagulation cannot be given, we can do pulmonary vein isolations. Also, we can do left atrial appendage occlusion. You can see the left atrial appendage. Yeah. So, and also here beneath the left atrium, there is that atrioventricular groove through which the vein of Marshall travels. And also beside that, the LCX, that is the left circumflex artery, also travels through this groove. Okay. And this is the right ventricle, this is the left ventricle. You have to know the difference between the right and the left ventricle. Mainly, the right ventricle is the smaller ventricle with thinner wall, which is 1/3 of the wall thickness of the left ventricle, and the interior of the right ventricle is again ridged. It is trabeculated, right? And there is a band of tissue which is called moderator band. Here in this diagram, we cannot see very well. This band of tissue near the apex of the right ventricle is called moderator band. So trabeculated, thin-walled, smaller ventricle is the right ventricle. Non-trabeculated, smooth-surfaced with thicker walls ventricle is called the left ventricle. The left ventricle is obviously has more contractility and more power that pumps blood. Why I'm saying it is called because sometimes this thick-walled ventricle with smooth surface, it will lie on the right side. Then also it will be called the physiological left ventricle. So left and right, their function determines their structure, not their positions, right? In different congenital heart disease, the left ventricle will lie on the right side, right? But then also we'll call it physiological left ventricle. You can see the chordae, these are the papillary muscle, this is the chordae tendineae, these are the cusps. This is the mitral annulus. Now, I want to talk about triangle of Koch. Can anybody say what is the importance of triangle of Koch? What lies in here? This is an imaginary triangle. Then nobody has drawn a triangle. This is an imaginary triangle. There's an important structure that lies here. Is the AV node, atrioventricular node. I just mentioned that AV node lies in the endocardial surface. It is bordered by the coronary sinus opening on one side, the tricuspid valve leaflet on one side, and there is a tendon of Todaro, a ridge. This is called the triangle of Koch, which is the site of the AV node. This is also very important in electrophysiology for ablation procedures. Now coming to this pressure diagram, the pressures and saturations of all the large vessels and all the chambers of the heart has to be memorized quite well. So aorta, the pressures are, systolic pressures are 100 to 140, diastolic 60 to 90. The LV pressures are 100 to 140. The diastolic pressures are 3 to 12. There's an important figure. It's called the LVEDP. That is left ventricular end diastolic pressure. Sometimes it will come in MCQs and it is very useful for many interventions. The LA and RA pressures are relatively low. LA pressure is 1 to 10, mean pressures, millimeter of mercury, and RA is 0 to 8. Mostly RA pressures are slightly lower than LA or sometimes equal as well. RV pressures are 15 to 30 systolic and 0 to 8 diastolic. If you can note that these diastolic pressures are equal to the corresponding atrial pressures. Same for LA and LV, same for RA and RV. That allows the smooth, so whenever the blood is flowing for RA to RV or LA to LV, there is not much pressure difference. It just flows across. There should not be much turbulence. Okay, because there is not much pressure difference during the diastolic opening of the atrioventricular valves. So if there is pressure difference, there will be turbulence and there will be formation of murmurs. So here, this is how the blood flows. This is the PCW, that is pulmonary capillary wedge pressure, then goes to LA, then LV to aorta. Any confusion anywhere, please feel free to ask. So there is a difference between right ventricle and left ventricle. As I said earlier, left ventricle has more contractility, has 3 layers of muscle fibers, thicker wall, higher energy cost, more oxygen demand, and commands higher coronary blood flow, has a longer action potential. Okay, even the MHC expression is different in right ventricle and left ventricle. All these things become very important in ischemic heart disease. So, coming to ischemic heart disease, a patient presents with STEMI and complete AV block at the ER, which is the most likely involved coronary artery. I hope you have some idea about coronary arteries. So, can anyone volunteer? Just this
Right
question.
coronary artery. Right coronary artery.
Right coronary artery. Why did you say that?
Because this right coronary artery supply the inferior part of the heart
Hello, Salam alaikum, sir. How are you?
along with the AV node
Alhamdulillah.
to the posterior descending artery. So in such cases, you will get both STEMI and
India, we
AV
are from
block.
India.
Yeah. So, AV node is mostly supplied by the right coronary artery.
Right coronary artery.
I'm hearing some noise. Yeah. So, yeah, you're right. The AV node is mostly majorly supplied by the right coronary artery. And hence, if nothing is mentioned, what kind of STEMI it is, inferior, anterior, whatever, if it comes with a complete AV block, most likely it is RCA, right? We'll go to the next coronary circulation. So coronary circulation, as you can see in the diagram, there are traditionally three main coronary arteries. There are very many coronary anomalies, but we'll talk about the normal things first. So this is the left coronary artery. All these coronary arteries arise from the sinus of Valsalva, that is at the root of the aorta. So most of these coronary arteries get blood in diastole, not in systole, because in diastole we have blood pooling in the sinus. The aortic valve is closed, the sinuses are filled with blood, and at that time the coronary arteries get supplied. The largest and the one that supplies the most part of myocardium is the left coronary artery, which divides into LAD and LCX. So this is the left main. Left main stem goes into LAD, which runs through the anterior interventricular groove and divides into LCX, which winds around into the atrioventricular groove, goes posteriorly, and ends near the crux if it is non-dominant. If it is dominant, it will send down a posterior descending artery through the posterior interventricular groove. This is the right coronary artery coming from the right coronary sinus of Valsalva, goes through the AV groove again, winds around, goes back, and gives the posterior descending artery. In how many cases? So this is what we are talking about, coronary dominance. So approximately 80 to 85% cases, the hearts are right dominant. That is, the RCA gives rise to the posterior descending artery, which supplies the posterior portions of the heart. Left dominant only in 10%, in which the PDA comes from the LCX. Then the LCX is very large size. In this left dominant cases, the RCA is diminutive. It's very small, ends very early. And codominant, when PDA comes from both the RCA and the LCX. In those cases, in this codominant cases also, the RCA is larger than the LCX. So LAD is the largest, covering 45 to 55% of the LV myocardium. LCX covers around 40 to 50% of the LV in left dominant system and 15 to 25% in right dominant system. In any situation, if you note very well, in any of the situations, 70 to 80% of the LV myocardium is supplied by the left coronary artery. So if we have a block here, which is the left main, then the heart is at very high risk. Immediate LV dysfunction happen, patient goes into left ventricular failure, shock, and everything. So what is the third sinus? It's the non-coronary sinus, which is placed posteriorly. Usually no coronary arteries come through that. Coronary perfusion, as I mentioned, is mostly during diastole. RCA supplies RA-RV and inferior LV. SA node in 60% cases, but AV node in 90% cases, which was the reason for your answer that most of the AV block happen in inferior wall MI, which part is supplied by the right coronary artery. Thebacean veins are small intramural veins draining directly into the chambers. Coronary flow is phasic, maximal during diastole, autoregulated by metabolic demand, that is adenosine, nitric oxide. The coronary flow is not like flow of any other arteries, since heart has to be kept beating all the time. So whenever there is a decrease in flow, there will be local secretion of adenosine or NO, and we will get uh, temporary localized coronary, these are not coronary arteries anyway, localized dilatation, which will increase the blood flow in those areas. Right coronary flow, interestingly, occurs both in systole and diastole. Since RV pressure is low, this right coronary flow, why does it matter? Actually, the blood flows because of the difference of pressure created between the sinus and the cavity pressure. So imagine the LV cavity pressure in systole. It's very high, right? It's 120 or something. So hardly there is any difference in the pressure between the aortic sinus and the LV cavity. And hence, there is not much flow in systole. But imagine right ventricle. Right ventricle systolic pressure is only 25. So whether it is diastole or systole, there is always a pressure difference maintained between the aorta and the right RV cavity, and hence right coronary flow occurs both in systole and diastole. Subendocardium is the most vulnerable to ischemia because all these arteries are epicardial vessels, so they run above the heart. So the last branches, the terminal branches, reach the subendocardium, which is most vulnerable to ischemia. Collateral flow develops gradually in chronic CAD, protecting myocardium. Sudden occlusion without collaterals causes STEMI. So, well developed collaterals may make severe CAD appear clinically silent, which is why very old patients with multiple risk factors, they will not suddenly die even when a STEMI happens. But the mortality in young patients with a single epicardial vessel block is much higher because they did not have severe coronary artery disease before. They did not get time to develop collaterals. So their mortality is much higher than the older patients. Here I have a diagram of the coronary venous drainage. The only thing you need to know is this coronary sinus which drains into the, we just mentioned, which chamber of the heart does it drain into? The right atrium, right? It drains into the right atrium. It takes the main branches are this one, the great cardiac vein that starts from the posterior interventricular groove, winds around the apex, comes into anterior interventricular groove, again winds around the AV groove and joins the left marginal vein to form the coronary sinus. Why is coronary? All these veins you need to memorize, but these are low yield points. The only thing is causes of coronary sinus dilatation in echo might come, and also the clinical implication of coronary sinus. So SA node artery usually arises from RCA, AV node from RCA. Occlusion of LAD causes anterior wall MI. As I told, LAD supplies most of the anterior wall, and we'll go back 2 slides. See, it supplies most of the anterior wall and this one, anterior 2/3 of the interventricular septum with these septal arteries. These are the septal branches of LAD, which goes inside the interventricular septum, and these are the diagonal branches which goes towards the margin, towards the left margin of the heart. These are epicardial. This delves into the septum. So interventricular septum and anterior wall is supplied by LAD. So anterior wall MI or anteroseptal MI is caused by an LAD occlusion. RCA supplies the conus. The conus is the part of the RV. Then it supplies many of this angular, these branches. And there's marginal arteries, AV nodal arteries, SA nodal arteries, then goes on to supply the PDA, which again supplies the posterior part of the interventricular septum. So coming back here, occlusion of RCA thus causes inferior MI with or without AV block. Occlusion of LCX causes lateral wall MI. LAD is also known as a widow maker because you can understand the chances of the mortality in anterior wall MI is much more since it supplies most of the LV, myocardium, LAD. So it's called the widow maker. The chances of fatality is higher. Bundle of his and bundle branches are supplied by septal perforators from the LAD. So in anterior wall MI, often we see there is LBBB or RBB pattern and there is increase in the QRS voltages because a lot of LV myocardium is gone. So the signal, the electrical signal takes longer time to depolarize the ventricle. Hence, LBBP, RBBP pattern, widening of the QRS, all these things happen more commonly with the anterior wall MI. What is coronary steal phenomena? Vasodilators like dipyridamole divert blood from the diseased vessels to normal ones, worsening ischemia. So, when we have an acute coronary syndrome or MI, vasodilators are ideally contraindicated. We should not be giving these vasodilators. Myocardial bridging is actually physiological, normally present in many people. This is a segment of the coronary artery where this coronary artery from the epicardial surface dips down into the myocardium of the heart, then again comes up in the epicardium. So it has a intramyocardial course. And so whenever systole happens, this intramyocardial, the part of the artery which is present inside the myocardium, gets compressed. There is a milking effect. This in mild to moderate cases does nothing, but in severe cases may cause ischemia during each systole to the part supplied by that artery, the part of the myocardium that is supplied by that artery. Coronary sinus branches, lateral or posterolateral, are used for CRT. CRT, cardiac resynchronization therapy. I think all of you know by now. It is one of the CIED, that is cardiac implantable electronic devices. One is our pacemaker, then came our ICDs, then came our CRTs, Now we have newer devices, like we do his bundle pacing, we do Bachman bundle pacing, LBBB pacing, and also we have leadless pacemakers now. Anyway, so coronary sinus branches are used for CRT, left ventricular lead placements. Coronary sinus dilatation is seen most classically in persistent left superior vena cava, but can also indicate raised RA pressure for any reason. It can be pulmonary hypertension, tricuspid regurgitation. Anything that increases RA pressure due to volume or pressure overload will cause increase in the size of the coronary sinus as seen in the echo. We are coming to embryology. I will go really fast in here because only a few questions come from here. The heart derives from embryonic mesodermal germ cell layer. There's a splanchnopluric mesenchyme. This might come as a MCQ. By day 19, the endocardial tube begins to form. This is the whole embryo in the cranial region above the heart. Then the folding will occur and the heart will come in front of the brain. But before, in the initial stages of development, is in the cranial most part. This part is called the cardiogenic area, and blood vessels start to accumulate here to form two endocardial tube which recanalizes by 19 to 20 days, and then they fuse with each other to form a common cardiac tube anteriorly. Okay, so and this tube is divided into 5 parts. The cranial most part is the truncus arteriosus, then bulbus cordis, then primitive ventricle, then the primitive atrium, and then we have the sinus venosus. So this is the venous end and this is the arterial end of the heart. Then from 23rd day, something called the morphogenesis occurs. That is, the heart tube starts to rotate. It starts to rotate clockwise and the arterial part is pushed cephalic and anteriorly. See here. So this is the shape of the heart on 24 days. By 35th day, this position of heart is received and all other septations and vessel formations start. So on day 23, as I already told about the morphogenesis, so we have to know what is formed, what forms from what. This truncus arteriosus part forms the arteries, major arteries, that is the aorta. This is the ventral aorta. It forms the anterior aorta, right? There is a dorsal aorta with which the branches of this truncus arteriosus will merge. I'll come to that. So this truncus arteriosus, above that there is aortic sac, aortic arch, and very many branches. To begin with, there are 6 aortic branches, and I'll come to that later. After below that there is truncus arteriosus. Beneath that, this is the bulbus cordis, which enlarges enormously. It forms majority of the right ventricle, and this is the inlet. Okay, the conus cordis. This is the primitive ventricle. The left ventricle is majorly formed by the primitive ventricle, and then this atrium, primitive atrium, goes behind. You can see it goes behind. This primitive atrium mostly forms the left atrium, and sinus venosus mostly forms the venous connections and the right atrium. Can anyone say which is the most common congenital heart defect in adults? Anyone?
Septal defect.
Yes, it came, no? The answer. Any confusion or query about that? Which is the most common congenital heart defect in adults? The question, the importance is in this word, adults. In adults, it is ASD. But if the question was what is the most common congenital heart defect overall, that is ventricular septal defect. This is true in adults because a lot of VSDs, many of them close during 0 to 5 years of age, especially the smaller muscular ventricular septal defects. So I'll come to the embryology of the aortic septum. I will go really fast. It was very easy. I think everybody knows. So this is the schematic diagram of the heart. This is from central fibrous body. The septum intermedium starts forming. Okay. This is the primitive atrium and part of the sinus venosus. Okay. So from roof of the primitive atrium, a septum primum, the first septum, starts developing. The gap between the septum intermedium and septum primum is called ostium primum. When it reaches the septum intermedium, there is some autolysis of the cells in the upper part, like in the roof part of the primitive atrium. that is called the ostium secundum. And this remaining part of the septum primum is called the septum primum that is fused with the septum intermedium. From this is the right side, right? From the right side of this previous septum primum, septum secundum starts developing, overlaps this septum primum like this. So there is a flap valve created here. This is the two-dimensional. This is, we are seeing from the cross-sectional area, this is the two-dimensional on face diagram. This is a flap valve created. So this area, this is the lower margin of the septum secundum, is called limbus fossa ovalis. This area is called the fossa ovalis. During the fetal circulation, this part remains open and blood flows from this side, from the right to the left. When the fetal circulation after the child is born, the left-sided pressures increase and this septum primum is pushed onto the septum secundum, physiologically closing this flap valve, right? So foramen ovals, in lot of people, the anatomical closure of the septum of this foramen doesn't occur, only the physiological closure. So the flap valve still remains. So we call it the propatency of the flap valve. And if it doesn't completely cover this septum primum, then there is a hole left, which is called the foramen oval, which is present in 25% of the adults. I'll come to ASD. The types of ASD, there are 4 types: ostium secundum, ostium primum, sinus venosus. In most of the books, it's mentioned 3 types, but the 4th one is always mentioned in congenital heart disease books. It's the coronary sinus type. This is not a true ASD. Coronary sinus, we all saw the coronary sinus opens in the right atrium. But if the coronary sinus doesn't have the roof, if the roof doesn't develop, then this coronary sinus directly communicates with the left atrium also before draining into right atrium. So the blood can flow from the left atrium to right atrium. So that is another type of ASD, but this is not a true ASD because it is not a defect of the atrial septum. Pathophysiology, left to right shunting at the atrial level, because obviously the left-sided heart pressures are higher. So first blood flows from LA to RA, then from RA to RV. So increase in blood volume in the RA and RV causes a chronic volume overload of these patients of atrial septal defect, which causes RA and RV dilatation and more blood in the pulmonary circulation, which causes pulmonary overcirculation. Over the time, firstly pulmonary circulation, it accommodates all the extra blood, but over time this hypervolumic state contributes to development of pulmonary hypertension. Clinical features: ASD patients are mostly asymptomatic and diagnosed mostly in incidental echocardiograms. Sometimes they present with exertional dyspnea, fatigue, and palpitations. These all occur in the 3rd or 4th decade of life. In the 1st or 2nd decades, usually always ASDs are asymptomatic. Signs and murmur, we have a wide and fixed split S2. This is a very high yield question. Many a time they repeat this. Wide and fixed S2. Classical answer is ASD. There are some other conditions which is out of our scope. Ejection systolic murmur can be heard in the pulmonary area due to increased flow. Mid-diastolic murmur in the tricuspid area. Because of increase, again I told you, a lot of blood comes into the RA and RV. So increased flow across the tricuspid valve also happens when the blood flows from the RA to RV. So even if there is no obstruction at the tricuspid valve level, there is increased flow, so increased turbulence and a murmur of tricuspid area is created, which is a mid-diastolic murmur. That is when the tricuspid valve is open. Epidemiology I mentioned because compared to the world in general, UK has a lot of ASD cases, and in PACES also you can expect ASD cases to be presented. This development of Eisenmenger syndrome is an important thing. Can anybody tell me what is Eisenmenger syndrome? Just in simple terms, what is Eisenmengerization of congenital heart disease?
Reversible of the shunt.
Yeah, reversal of the shunt. So reversal of the shunt occurs in PDA, VSD, ASD in ages. These are the mean ages. Around 19 years in PDA, around 22 years in VSD, and around 35 years in ASD. See, these values will differ with different studies, but what I want you to know that PDA happens first because PDA is a direct connection from aorta to pulmonary artery. So we are pouring a lot of blood directly into the pulmonary circulation. So pulmonary hypertension develops much faster. VSD, it is the next step. The blood goes from the left ventricle to right ventricle to the pulmonary artery. So the the compliance of the ventricle prevents the pulmonary circulation for some years. So pulmonary hypertension develops after a few years. And ASD is the most benign one because the connection is between left atrium and right atrium. They are anyway like having almost equal pressures. And the volume overload is mostly mitigated by dilatation of the RA and RV for many, many years. So Eisenmengerization happens usually in the fourth decade. Investigations, ECG shows RBBB, right axis deviation because of RA-RV dilatation, and left axis deviation in primum defects. It has a complex mechanism. If you want, I can explain later. One important sign is the crocheted sign, which is notching of the QRS complex in the inferior leads, that is the lead 2, lead 3, and AVF. Chest X-ray shows RA-RV. This is a typical chest X-ray for ASD, also very common, very typical. Anybody can, ask showing this X-ray. You can see these are the signs of pulmonary hypertension. Very prominent main pulmonary arteries, prominent right descending pulmonary arteries. There is a large right atrium. I just told you, bulging of the right border, which occupies more than 3 intercostal spaces. And there is an RV type apex. See, the apex is somewhere here, not here. The most outward point is somewhere here, not here. So this is RV type of diffuse apex with pulmonary hypertension with RA enlargement. This is a classical X-ray of atrial septal defect. Echo is diagnostic, but bubble study may show shunt. Bubble study we do when we cannot directly see an ASD, but we are suspecting an ASD might be there or a PFO might be there. In that case, we do a bubble study. We send the bubbles in through the venous side, that is through any of the systemic veins, through your brachial veins or radial veins. We do an IV cannula, send in some bubbles, and we have to wait. If the bubbles show in the left side of the heart within 3 cardiac cycles, then bubble study is positive. So an ASD or a PFO is present. Cardiac CT is only done in doubtful cases like sinus venosus, which cannot be seen on echo, or rechecking the margins before operation or any intervention. So fixed split S2 in ASD and risk of paradoxical embolism in PFO and ASD is there, stays there. ASD more after Eisenmengerization because there is reversal. So there is more chances of venous clots going into the arterial system and causing paradoxical embolism in various parts. It may be in the brain, maybe in the legs. Treatment is closure. Any hemodynamically significant shunt treatment is closure. It can be surgical or device based if hemodynamically significant. Medical management in Eisenmenger, when the reversal of shunt is already there, we should not be closing any of the shunts because it shortens the lifespan of the patient. And PFO is only closed in cryptogenic stroke when there are no other risk factor why a patient is having recurrent TIA or has had already a stroke. I wanted to discuss this ECG. This is a typical ASD ECG. You can see the RBBB is here. There is right axis deviation. How can we know about it? Not very prominent. 1 and AVF both are positive. So the axis is more or less okay, but there is some crocheted sign. You can see in some of the inferior leads. Can you see here? There is notching here. You can see here. There is some notching in here. In this one. So this is called the crocheted sign of right ventricle of ASD. Typical. Now coming to embryology of the ventricular septum and the spiral septum. The ventricular septum has 2 parts. You can see this is the membranous septum and the muscular septum. So membranous here, this is the central fibrous body. the two AV cushions form. AV cushions are the atrioventricular cushions that form on the either side. From these cushions, we will later form the AV valves, that is the mitral valve and the tricuspid valve. So this is the bulbous septum that comes from above. We read about bulbous cordis before. And this is the interventricular septum that rises from below. This is the primitive ventricle. This is the bulbous cordis. So this meet here. This is the membranous septum. This is the muscular septum. Okay. And this is the posterior structure. What is this? The primitive atrium. Here we can see already the interatrial septum is formed. Okay. This is one of the AV cushions. This again is complicated because this is called the spiral septum. Spiral septum divides we talked about the truncus here, truncus arteriosus, no? Here, the truncus arteriosus and aortic sac. So the division of the truncus arteriosus occurs in a spiral manner. There is twisting of these vessels while this septum is developing. So what happens is the pulmonary, when the septum in the inferior part, the pulmonary artery is in front, then it goes onto the left side of the aorta, then it goes behind the aorta. So aorta is firstly from the base, it is a posterior structure, then on the right side of the pulmonary artery, then goes anterior to the pulmonary artery. Site of most VSDs is membranous septum. VSD most likely to close are muscular VSD. Swiss cheese VSDs are multiple muscular VSDs, but Swiss cheese VSDs usually do not close. They have a high propensity to form clots and be a site of infective endocarditis. Okay, because they are very small and there is a lot of turbulence of the blood when the blood flows from the LV to the RV. VSD in TOF is ideally a malaligned inlet VSD. Okay. So this is again, this picture I put here to show you that the muscular portion of the septum can be further divided into three parts. That is the infundibular septum, the trabecular septum, and the inlet septum. Okay. So inlet is where inlet of the right ventricle, trabecular is the main apical part, and infundibular septum is the outlet portion. So any VSD here will be an outlet VSD, this an inlet VSD, this a muscular VSD, and any VSD here will be a perimembranous VSD. Okay. So VSD's type we already discussed: perimembranous, muscular, inlet or AV canal type, and outlet type. Pathophysiology. So this inlet, anything that we were talking about ostium primum, in any AV canal defect, which means the AV canals are not aligned properly. The interatrial septum, the interventricular septum, the AV valve, fibrous rings, they do not join as they should. So the defects that are formed are usually at the inlet. So an inlet VSD, if there is an ASD associated, what will be that type of ASD? An ostium primum ASD. Okay. Did I talk? Ostium primum ASD means near the AV canal, near the ventricular septum, membranous septum, there is a defect. That is the ostium primum type. Ostium secundum type ASD is actually a defect between the left atrium and right atrium at the level of fossa ovalis. Sinus venosus type is where the SVC and IVC are meeting the right atrium behind the left atrium and right atrium. That part of sinus venosus, if it doesn't develop properly, that will form a sinus venosus type of ASD. So coming back to the VSDs, pathophysiology is again left to right shunt at the ventricular level. Small VSDs have minimal hemodynamic effect because a lot of blood cannot flow from left to right, but there is a loud murmur because the pressure difference is maintained throughout the systole. Enough blood cannot be shunted to neutralize the pressure difference. So there is a loud murmur, and so there is more turbulence of blood. And wherever there is more turbulence of blood, there is more chances of infective endocarditis. Large VSDs, there is volume overload, LV volume overload, and early heart failure and pulmonary hypertension development. So in children, which one do you think will produce symptoms? The large VSDs, right? In infancy only, it will cause heart failure because of LV failure, RV failure, lot of blood in there, and pulmonary hypertension due to lot of flow into the pulmonary tree. Clinical features: small defects or small VSDs can be asymptomatic. Large defects presents with failure to thrive, recurrent chest infections, and heart failure in infancy. Signs and murmur. Classical murmur is a pansystolic murmur at the lower left sternal border. It may have thrill. Large VSDs will have softer murmur, and smaller VSDs will have louder murmurs. Loud and widely split S2, which will be variable, unlike fixed S2 in atrial septal defects. Okay. ECG will show both left ventricular hypertrophy and right ventricular hypertrophy, and this is also known as a Katz-Wachtel phenomena. Can you see in this ECG, if you look closely from V2, V3, V4, V5, we have very tall R waves as well as very deep S waves. So it signifies both the left and right ventricles are probably hypertrophied. So this is called the Katz-Wachtel phenomena. Sometimes present, not always present in VSD cases, but it is highly specific. Chest X-ray, there will be cardiomegaly as we can see in this classical chest X-ray, and pulmonary plethora, lots of blood. You can see it is all white, the pulmonary fields. So pulmonary plethora because of hyperdynamic pulmonary circulation, right? All this ASD, VSD, PDA, all of this will have more flow into the pulmonary circulation. So all of them will have pulmonary plethora till they become Eisenmengerized. When they are Eisenmengerized, due to the rise in the pulmonary arterial pressure, the pulmonary artery will not allow a lot of blood to flow in. In that case, there will be blackness of this outer region of the X-ray. Okay, so we can understand whether this has Eisenmengerized or not from the X-ray as well. Cardiac CT is often done pre-surgically for planning. Most common congenital defect overall, and complications are Eisenmenger syndromes and endocarditis. Treatment is small VSDs. We can follow up for many years if it is not hemodynamically significant. Moderate is symptomatic or volume overload, then we should close surgically or by device in 9 to 12 months of age. If it is asymptomatic, then we usually close between 3 to 5 years of age when the child is a little bigger. Large ones are always hemodynamically significant and should be closed between 3 to 6 months of age. Also, in complications like aortic regurgitation, left ventricular outflow tract obstruction, and infective endocarditis. These are three common complications. In all these complications, closing the VSD is indicated. This is the embryology of the venous system. As I was talking to you, these are three horns of each of the sinus venosus, the lowermost part of that heart tube that we were talking about. Each horn is forms cardinal vein, umbilical vein, and vitelline vein from lateral to medial part. So these umbilical and vitelline veins, most of these will dry up. Only some will stay. This on the right side, the vitelline vein here forms the IVC. The left-sided vitelline and umbilical vein will like atrophy and will undergo atrophy, and this left-sided common cardinal vein, the inferior part and superior part, they will stay as smaller veins. This superior part of this sinus venosus and anterior part of the cardinal vein will form the SVC, and this part of the right part of the sinus venosus horn, right horn of the sinus venosus, will form the posterior surface of the right atrium. This is what I was telling you. If this is deficient, then blood will flow from RA to LA. This is called the sinus venosus type of ASD. And coronary sinus is formed by, you see, the left horn of the sinus venosus. This is the coronary sinus, the main vein that drains the heart. Okay, and this is the roof. If this roof is absent, then again the LA and the RA is connected through this coronary sinus. This is called the coronary sinus type of ASD. These are again venous developments. If you want, I'll go into details, otherwise no need. These are aortic arch developments. You can see this is the primitive, this is the aortic root, ventral to the pharynx. This is the dorsal aorta, which separately develops as a blood vessel. These two are connected laterally by arches, 6 arches on either side, left and right. So what happens to these arches? The right and left horns, these are the horns of the aortic sac, right? The first aortic arch degenerates, second here, the first and second aortic arch degenerates. The third aortic arch forms the internal carotid artery from the third aortic arch and part of dorsal aorta here, both sides, right? External carotid artery is a bud from the third aortic arch. See, this is the third aortic arch, a bud originates from here. This is the external carotid artery. Common carotid artery from the proximal part of the third arch. Here, the proximal part of the third arch, two common carotid arteries. Fourth arch is complicated. Brachiocephalic artery forms from the right horn of the aortic sac. This is the right horn, which divides into the fourth and fifth aortic arches. Fourth one forms the brachiocephalic artery, distal part of the brachiocephalic. This is the common carotid artery. The proximal part is brachiocephalic artery, and the fifth arch from here will form the subclavian artery. Here, this fifth arch will form the arch of the aorta, right? Here, arch of the fourth one will form the arch of the aorta. The pulmonary arteries are the proximal part of the sixth aortic arch. Here, it gets separated from the sixth aortic arch. Ligamentum arteriosum form ductus arteriosus, distal part of the left aortic arch, this one. And descending aorta from dorsal aorta below the level of fourth aortic arch on right side, it degenerates. So this is the pulmonary trunk. Here it is formed by the truncus arteriosus. These are the six aortic arches. This is the degenerated ductus arteriosus, which is open during the neonatal period, after open during the fetal period, then it closes and forms a ligamentum arteriosus. Okay. So which drugs promotes this PDA closure if the PDA is open during birth? Can anyone answer? Hello?
Indomethacin.
Prostaglandin.
Indomethacin.
Yeah, the correct answer is indomethacin. Prostaglandin E infusion, this is the common confusion many of you have. PGI infusion is used in persistent patent ductus arteriosus only when the child or the infant has a duct dependent circulation. So PGEI keeps it open and indomethacin keeps it closed. So indomethacin infusion is given for PDA closure in smaller PDAs. Okay. PDA, the pathophysiology is similar, persistent communication between the aorta and the pulmonary artery, so left to right shunt, volume overload of the pulmonary circulation, pH development, reversal of shunt. Risk factors are premature babies, congenital rubella, hypoxia. Clinical features, small PDAs are often asymptomatic, larger ones present with heart failure, poor growth and recurrent infections. Signs and murmur, the famous murmur is called the Gibson's murmur. PDA, which is a continuous machinery murmur heard both in diastole and systole in the left infraclavicular area. Other signs are bounding or collapsing pulse with wild pulse pressure. This is a classification according to the morphology of patent ductus arteriosus. It's called the Kirchenko classification. Kirchenko classification, and this type A or conical PDA is the commonest one. So we close these PDAs with conical devices. Investigation ECG will show LVH, the left ventricular hypertrophy and left atrial hypertrophy, because we are bypassing RA and RV, right? The volume overload happens at the aortic level. Aorta to pulmonary artery goes into the pulmonary circulation. All these extra blood are directly coming into the LA and LV. So there is LVH and LAH. Cardiomegaly is seen in the X-ray with pulmonary plethora. One point to mention is ECG and X-ray are very non-specific in PDA. From ECG or X-ray, you cannot diagnose PDA. Echo is needed, which confirms the flow. Closure promoted by indomethacin and PGI infusion is used to keep the PDA open in duct-dependent lesions. Okay. So this is one X-ray of a PDA patient, PDA child actually. You can see this is actually the pulmonary bay, which should be concave or straight. It is so much dilated because a lot of blood is going from the aorta into the pulmonary artery. and there is some left ventricular enlargement here. Which of the one of the following is not a palliative procedure in tetralogy of Fowler? TOF, anybody has read? Can you tell me answer to this? This might be a little tricky. Yeah, so which is not a palliative procedure. Intracardiac repair is the definitive procedure in TOF. It is the treatment of choice, and this cures the patient. Like, this is the final surgery. So this is not a palliative procedure. All these three are palliative procedures, and you have to know what connections. What are connected in the Watterson shunt, Blalock-Taussig shunt, modified Blalock-Taussig, Potts shunt. We'll come to that later. RVAT stenting is done in very small, narrow RV outlets. Okay. So TOF is tetralogy of Fowler. So what is the tetralogy? 4 components. Non-restrictive VSD, very important to mention non-restrictive. If it's a restrictive VSD, then it is not a TOF physiology at all. Even if all 3 others are present. So it has to be a non-restrictive VSD, overriding of aorta, RV outflow tract obstruction in form of pulmonary stenosis in some patients. RV outlet stenosis also occurs, and RV hypertrophy. So what is the pathophysiology? There is RVOT obstruction. So see, this is a normal heart. This is the TOF heart. So there is an RVOT obstruction. So this RV blood cannot go easily into the pulmonary artery, but they have a bypass tract, very nice big non-restrictive VSD. So instead they will go into the aorta. It is malaligned. Can you see? The septum should come here between the pulmonary artery and the aorta, but it is malaligned. It is just ending below the aortic root. So the blood directly flows, deoxygenated blood flows into the aorta through this large malaligned non-restrictive VSD. So there is a mixed blood that is flowing through the aorta, deoxygenated blood, and hence the patient develops cyanosis. This chronic hypoxia in the fingers also develops clubbing, and there are many other complications. There are tissue hypoxia causing lots of things. Interestingly, these TOF patients will have very less coronary artery disease. Heart attacks in TOF patients are very rare because chronic hypoxia will cause chronic dilatation of the coronary arteries. They are usually huge. Anyway, clinical features are cyanosis, clubbing, polycythemia, and TET smell or hypoxic spells. Hypoxic spells or TOF spells are the medical step where MBBS and MD level our doctors are required to treat. Our ICU specialists, our critical care specialists are required to treat the patients. The intracardiac repair stage, the Blalock-Taussig shunt repair stage are done by the CTVS surgeons, right? So you have to know very well about the TET spells. Signs and murmur, ejection systolic murmur is heard in the pulmonary area due to RVOT obstruction. Not due to the VSD, because VSD is non-restrictive. There cannot be a formation of any murmur. There is a single S2 as A2 is soft or absent. There is cyanosis and clubbing. Investigation, chest X-ray is a very classical boot-shaped heart. You can see this is the RV apex, upturned boot-shaped apex, and there is hollowing. So the main pulmonary arteries are underfilled. The pulmonary bay is underfilled. So this is concave. So it looks like a boot-shaped heart with right ventricular hypertrophy, upturned apex, and oligemic lung fields. You can see these lung fields are much blacker. When we saw the ASD and VSD, they are much whiter because there is pulmonary plethora, more blood flow. In TOF, there is pulmonary oligemia or less blood flow and black X-rays. Echo is diagnostic. Examples, most common cyanotic congenital heart disease. Squatting increases systemic vascular resistance and improves cyanosis. Classic clinical rule. The patient will give history of squatting, and surgical correction is the definitive management. I wanted to talk about the ECG also. In ECG, you can see right axis deviation, RVH. All these things happen in ASD also, right? Hai. So TOF, there is a unique pattern. You can see here in V1, there is a tall R wave, which signifies RVH. But V2, suddenly the QRS complex becomes negative. This is called early transition. This is very typical of TOF. Very typical. There is no large R waves in V2 or V3. They are all small R waves with poor R wave progression. So here you can see large RA. This is right atrial enlargement, which is signified by this is P pulmonale, right? Any P wave which is more than 2.5 millimeter, it is P pulmonale. So there is right atrial enlargement, there is right ventricular enlargement, and early transition from V1 to V2, which signifies this is a TOF ECG. Okay. So TOF management, there are three important parts: intracardiac repair, the CDVS people will do. Number two is treatment. You just need to mention it in either paper 1, paper 2 or PSS. No detail is asked. Number two is treatment of cyanotic spells. This is the most important part. So how do cyanotic spells actually occur? In stress, sepsis, infection, when the baby is crying, when children are small, at that time, or say vasodilating drugs are used, or beta agonists are used, or procedures. So beta agonist procedures crying, they cause infundibular muscle spasm. Infundibulum is the outlet, RV outlet, right? And vasodilating drugs will cause reduced systemic vascular resistance because there will be dilatation of the peripheral arteries. The afterload will decrease, decreased SVR. If there is decreased SVR, what happens? There is more tendency of blood flow through the aortic orifice. If there, so it increases the right to left shunt because infundibular muscle spasm is there. Blood cannot go into the pulmonary artery, so it preferentially more and more goes into the aorta. So more and more deoxygenated blood is going into the body through the aorta, through the arterial system, increasing hypoxia, acidosis, increasing PaCO2, which in turn increases the pulmonary vascular resistance. Increased pulmonary vascular resistance will cause decreased flow through the pulmonary circulation. So decreased flow from RV to pulmonary artery and increased flow from RV to aorta. So this is a vicious cycle. It keeps on increasing. So more and more deoxygenated blood, the child becomes more and more cyanosed. So what are the initial management? Some of the management the child learns on its own. That is the posturing. Any squatting or cross-legging causes increased in the peripheral vascular resistance and breaks this vicious cycle. In hospital, what we need to do is calm the child, minimize the stimuli so that these stimulations decrease. Knee to chest position is a squatting equivalent. This will also cause increase in the systemic vascular resistance, which will cause decrease in coming of the deoxygenated blood into the aorta, right? Oxygen, if not causing distress, this is an NHS protocol. So they are writing cardiologist register or ANP review. In any of this emergency situation, anyway, you need to inform the cardiac register or the consultant. If no improvement or suboptimal, commence patient monitoring, ensure resuscitation. Morphine is given for pain relief, is also a sedative, and so morphine will also try to break this cycle, right? So, but it is cautiously given in infants less than 3 months of age. If no improvement, again, then insert IV or IO cannulation, give sodium chloride, which causes 5 to 10 ml per kg of sodium chloride to increase the volume to battle the acidosis. If no improvement or suboptimal, actually general anesthesia, all these things can be done. IV phenylephrine can be given, which again increases the peripheral vascular resistance and breaks this cycle. And IV esmolol can also be given to reduce the heart rate, beta blockers, right? Or in form of bolus or in form of infusion. You won't be asked the dosage, but you need to know the name of the drugs: esmolol, phenylephrine, morphine, calming down, oxygen, and general anesthesia if needed. So this is the treatment of TOF. If TOF tetralogy falla is duct dependent meaning the right side of the heart is either so small or the conduits are almost closed, like pulmonary atresia, tricuspid atresia. In those cases, neonate has to be operated as soon as possible, ASAP. Refer to pediatric cardiac surgeon and get the patient operated. Complete repair can be done if the pulmonary arteries are well developed. If not, then we need to do this shuntings. If the patient is not ductus dependent, then we can wait. If the patient, if the child is symptomatic, again go for neonatal operation. But if no symptoms are there, just a little bit of hypoxia on your pulse oximeter, just a little bit of cyanosis, but no symptoms, then elective operation has to be done by 6 months of age. Any elective operation has to done to any of the adults. Even if you find a 15-year-old guy who has TOF, you have to send the patient to CTVS for surgery. So these are the palliative shunts that are done. Classic Blalock Taussig used the right subclavian artery used to be transplanted into the right-sided pulmonary artery. This is a classic one, no more, not done nowadays. This modified Blalock Taussig is done. It uses a Gore-Tex tube, connects this brachiocephalic or the right subclavian junction with the right pulmonary artery. This is the Waterston shunt. It is connection between the ascending aorta and the right pulmonary artery. And this is the Potts shunt, which is a connection between the left pulmonary artery and the descending aorta. So TOF, we end with TOF. We come to cardiac physiology, where we'll discuss about heart sounds, murmur, cardiac cycles, physical laws, and fetal circulation. Stop me anytime if you are finding it boring or you want me to say something different, talk about valvular maybe. So this is the cardiac cycle. So we have the ventricular systole and diastole. What are the steps? What are the different phases? Isovolumetric contraction means the volume of the ventricles remain the same. There is increase in wall stress, increase in pressure inside the cavities. The ventricles are preparing to eject the blood. Then there is ventricular ejection. Whenever this semilunar valves will, this is the time the semilunar valves will open and the blood will flow from the ventricles into the aorta and the pulmonary arteries because of huge pressure differences. And then there will be ventricular relaxation. This is the diastole. The diastole occupies 0.3 second, 0.5 second, and this systole occupies 0.3 second, right? Here we have a division, you can see. In diastole, ventricular diastole, the first step is isovolumetric relaxation. So the volume remains same and the ventricle starts relaxing, decrease in wall stress, decrease in intraventricular pressure. So when these intraventricular pressures become so low that they become lower than the atria, then this atrioventricular valves open, and then there is the early ventricular filling phase, and this is the late ventricular filling phase, which is caused by the atrial contraction, active filling of the ventricles by the contraction of the atria. Then again the heart goes into the ventricular contraction phase. So total 0.8 second, 0.5 for systole, 0.3 for diastole, and we know the reasons of isovolumetric contraction and relaxation, that is to open the valves and create a pressure difference. This is a famous diagram. Can you tell me, can anyone tell what is the name of this diagram which shows the cardiac cycle? Is anyone hearing? Can anyone say? Okay, so this is called the Vickers diagram. In Vickers diagram, we see the pressure tracings of, here yellow is the atrial pressure, blue one is the ventricular pressure tracing, and these are the valve openings, see? And this is the aortic pressure tracings. This is the ECG. We are showing at what time what happens. This is the R wave of the ECG. This is atrial depolarization. So just after this, see, the atrial pressure rises because the atrium contracts. So this is the late filling of the ventricles, and then there is start of the ventricular depolarization. This is the R wave, which coincides with the R waves. At this point of time, the mitral valve closes because due to increased intraventricular pressure, the AV valve, mitral or tricuspid valve, closes. And then there is ventricular contraction. This is the huge pressure increase in the ventricles. Initially, it is isovolumetric, and then whenever the pressure rises and becomes more than the aorta, the aortic valves or the pulmonary valves, in case of right-sided heart, opens, and there is blood flow into the arteries, and hence aortic pressure is at the highest point here, right? After this is the small period of isovolumetric relaxation, after which the AV valves again opens, and these are the diastolic phase. This is the diastole. from T to P in the electrocardiogram. Auscultatory areas, we all know, aortic area, right of sternum and second intercostal space. Pulmonic is left of sternum in second intercostal space. Erb's point is left of sternum at third intercostal space. Tricuspid area, left of sternum at the fourth intercostal space. And mitral is left of sternum at the fifth intercostal space on mid-clavicular line. This is the classic one, but ideally we should always auscultate at the apex, wherever the apex is. It may not be here. Wherever the apex is, we should auscultate. So these are the murmurs that are found in different areas. In pulmonary area, systolic murmur, we can hear our flow murmurs, as we already read. In ASDs or VSDs, we find flow murmurs in the pulmonary area. Or if there is pulmonary stenosis, there is turbulence, we can hear systolic murmur. In tricuspid area, we hear systolic murmurs of the TR and VSD, tricuspid regurgitation and ventricular septal defect. And in diastole, we can hear murmur of TS and ASD. Why? In ASD, there was more flow through the tricuspid valve, so we can hear a diastolic murmur there. In mitral area, systolic murmur is almost always MR. In diastole, we hear MS, that is mitral stenosis murmur. This is the neo-aortic area. Here in diastole, we can hear aortic regurgitation or pulmonary regurgitation murmur. In systole, in this neo-aortic area, we hear murmurs of hypertrophic obstructive cardiomyopathy, HOCM. Systolic murmurs we hear in the aortic area, aortic stenosis, aortic valve sclerosis, or flow murmurs. Which auscultatory finding is always pathological? Can someone say? Just take a guess. Which is always pathological, never happens in a normal person.
Click.
Yeah. What?
D.
Yeah,
D.
it's S4 actually. It's S4. In some places, it will be written that S4 can be physiological, but it is hardly so. In old people also, S4 happens because of stiff ventricles, which denotes the presence of diastolic dysfunction. So those are not normal people. So S4 cannot be found in normal people, but all these three can be found in normal people. So these are the heart sounds. S1 caused by closure of the AV valves, normally hard. S2 caused by closure of semilunar valves. S3 is caused by in physiologically found in young patients with rapid ventricular filling in early diastole, especially in tachycardia. But in old,
Do you have some skirts?
yeah,
No,
hello,
skirts not fitting.
hello, yes, ma'am. In chat, is someone writing anything? Could you please repeat when vasodilatation? Sorry, I just saw the chats now. Vasodilator should not be given. Yeah, vasodilator should not be given. Vasodilators should not be given in MI. The only vasodilator that is allowed in MI is NTG. In case of persistent pain. Okay, VSD, that was the correct. Jug handle appearance, water sun, infundibular. No, that answer was intracardiac repair, infundibular hypertrophy. Infundibular hypertrophy, yeah, those are consequences. Yeah, can you write the question in the chat box? If somebody has any question, I'll answer. Yeah, click, you had answered click, right? Yeah, any ejection clicks are abnormal, but clicking sounds may be heard in very young or thin-chested individuals with opening of normal aortic valve as well. Or even clicks, the splitting of second heart sound may be heard as clicks in many individuals. So the correct answer is S4. S4 is again specific for a common heart disease. Can anyone tell what is it? In HOCM. Okay, in HOCM, S4 is very prominent, present in many of the cases. And S4 is also another quiz point is S4 is also the first auscultatory finding in acute myocardial infarction. Preconditioning, Thebasian. Thebasian, someone had answered, no? Very good. Okay, so we are moving on. These are S1, S2, causes of loud S1, soft S1, loud S2, soft S2. Just remember, loud sounds are always due to increased transvalvular gradient. So in mitral stenosis, there will be loud S1. In tricuspid stenosis also, there will be loud S1. In tachycardia, there will be loud S1. Why? In tachycardia, the diastole shortens more than the systole. So the valves are way far apart during diastole. Suddenly they have to close because diastoles are very short. So closing of the AV valves happen with a loud bang. So S1 is loud. So in tachycardia, S1 is loud. In mitral valve prolapse also, same thing. Mitral valve prolapse means mitral valve is very large. So if you're closing a very large door instead of a small door, there'll be more excursion of the valve reflex. There'll be a louder sound. So high S1. Low S1 is caused in bradycardia. Increased distance from the heart means, pleural effusion in obese people, or inappropriate position of the AV valves like mitral regurgitation. Soft S2 is caused by decreased aortic diastolic pressure, improper valvular apposition, again in AR, calcified immobile valves, and decreased systemic arterial pressure. Loud S2, again, I told you, if transvalvular, if the gradients are high, which will happen in systemic hypertension, there will be loud S2. In coarctation of aorta, same, because the proximal part of the ascending aorta will have higher pressure in cases of aortic aneurysm. S3 is usually present in hyperkinetic states or heart failure. When S1, S2, S3 is present, it's called a gallop rhythm. When S1, S2, S3 and S4 is present, it's called a quadruple gallop. S4 is present in ventricular hypertrophy, more commonly in HOCM. Ischemic heart disease, I told you in AMI, the first auscultatory finding is S4. In ventricular aneurysms or hyperkinetic state that cause forceful atrial contractions. Normal splitting, wide splitting, fixed splitting, and paradoxical splitting. Why does splitting occurs at all? S1 is also split, but it is split. The interval is so small that our ear cannot discern. But S2 we can discern because A2 almost always closes before P2. This happens because of the higher compliance and lower pressure and lower resistance of the pulmonary circulation. So the pulmonary circulation allows a longer time of RV emptying, but our peripheral vascular resistance or systemic pressures are much higher. So aortic emptying is much faster, LV emptying is much faster. That is normal splitting. Wide splitting occurs anytime when the RV is even slower, like a right bundle branch block or pulmonary hypertension with right heart failure. Right heart failure means the RV cannot pump well, so it takes longer time. Outflow obstruction of right ventricle, like pulmonary stenosis, taking longer time, or left ventricular pre-excitation, that the aortic valve closes early, like WPW syndrome. Fixed splitting occurs in atrial septal defects. Paradoxical splitting occurs in places where aortic closure is delayed, like aortic stenosis. More time is needed for LV emptying, or left bundle branch block. The LV is not contracting well, so it's taking more time. Narrow splitting or paradoxical splitting occurs in the same conditions. Murmurs is caused by turbulent passage of blood through any orifice or large vessel narrow area due to increased volume of blood. These are systolic or diastolic murmurs. Can anybody say what is an Austin Flint murmur? Austin Flint murmur? Yeah, it's actually a functional murmur. It's actually a functional murmur. We'll come to the valvular heart disease when we'll talk about this, okay? And mid-systolic murmurs are aortic stenosis, pulmonic stenosis, atrial septal defect, which is a flow murmur, and HOCM due to LV outflow tract obstruction. Hollow systolic or pansystolic are MR, TR, and VSD. Late systolic murmurs are mitral valve prolapse murmur. Other rare murmurs, like patent ductus arteriosus murmur, is a continuous murmur happening in systole and diastole. Grading, this is Levin's grading. This is more useful during your clinical examination. During PACES also, you have to mention the grade. Just remember, grade 4 is when thrill is palpable. All the murmurs where thrill is not palpable, you can call grade 2 or grade 3. And grade 4 is thrill is palpable. Grade 6 can be hard even without the stetho placed on the surface of the patient. These are dynamic auscultation. You don't have to memorize the whole table. All you need to remember is inspiration increases the right-sided murmurs and expiration the left-sided murmurs. And any increase in preload increases all of the murmurs. Increase in preload means rapid squatting or passive rising, except MVP and HOCM. These are important clinical cases. Their murmurs will decrease with increase in preload. Physical laws in cardiology, I think today in the paucity of time, am I audible though? I just want everyone's answer that we going to talk 15 minutes more, or do you want to end the class now? Then I'll just discuss the end part and continue with this in the second session. Am I audible? Should I continue with the class or for 15 more minutes or end the class here? Okay. Physical laws in cardiology. These are, see, some of the physical principles that we need to know. I'll come back to this later. We'll talk about valvular heart disease a little. These are mitral stenosis, regurgitation, MVP, aortic stenosis, aortic regurgitation, bicuspid aortic valve, tricuspid regurgitation, rheumatic heart disease, infective endocarditis, and prosthetic heart valves. All very important for part 1, part 2, and your PACES exams. Mitral stenosis, almost always rheumatic in 90% of the cases, are rarely congenital. Sometimes in older people, we'll have calcific, which is also called mitral annular calcification, and sometimes is in post-radiation cases. It's one of the commonest cases in the PACES exam as well. Symptoms is dyspnea and exertion, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, and palpitations from atrial fibrillation and systemic embolic events. Signs and murmur, clinically there can be malar flash, which is not very appreciated in Indian patients, but commonly asked question. Apex beat is tapping with a loud S1 and opening snap after S2. The murmur in MS is typically mid-diastolic rumbling murmur at the apex. Best heart with bell of the stethoscope in left lateral position. And does it increase or decrease in expiration? Okay, everybody is voting for a second session after this. I'll just finish with the mitral stenosis, then I'll conclude the class, and the rest of the things I'll be continuing with in the second session. So, yeah, so mitral stenosis murmur increases with expiration because it's a left-sided murmur. Ortner syndrome is hoarseness from LA compression of the recurrent laryngeal nerve. And this is on the right side, we have a pathophysiology of the mitral stenosis. Because of increased mitral gradient, the mitral stenosis will cause a pressure gradient between the LA and the LV, and there will be increase in left atrial pressure. Increase in left atrial pressure will cause left atrial enlargement and more blood into the pulmonary venous pressure, which will cause pulmonary venous hypertension and pulmonary edema. Eventually, over long term, it will cause pulmonary arterial hypertension, which on a backflow mechanism will cause right ventricular pressure overload with right ventricular hypertrophy, right ventricular enlargement, and tricuspid regurgitation. Left atrial enlargement will also cause atrial arrhythmias, and stasis of blood in the left atrium will cause formation of left atrial clots and left atrial appendage clots. ECG is typical P mitral. Here you can see this is a splayed notched P waves, which is also called P mitral. And presence of AF, atrial fibrillation, is extremely common in mitral stenosis. Features of RV overload, that is tall R waves in the V1, right axis deviation, and RBBB. In chest X-ray, there is not much straightening in this X-ray, but you will typically see a straightened left heart border with LA enlargement. See, you can see the splaying of the carina pulmonary venous congestion, more lines, these pulmonary lines, which are also called the curly lines. Do read about curly A, B, and C lines, curly lines. And very rarely cardiomegaly. It's very unusual to get cardiomegaly in mitral stenosis cases. In echo, there is doming of the anterior mitral leaflet, which is also called the hockey stick sign. On the short axis view, like end-phase view of the mitral valve, it appears thickened and like a mouth of a fish. So it is also called a fish mouth sign. Valve area less than 1.5 centimeter is called severe, and there can be signs of pulmonary arterial hypertension and TR on echo as well. Previously, this is a change in the old books. Less than 1 centimeter square is severe MR, but now less than 1.5 centimeter square of valvular area is called severe MR. So these are the echo views. Echo usually do not come, but some papers have had echoes in MRCP part 2. Only the classical pictures will come. This is fish mouth appearance of mitral stenosis in short axis view. This is the hockey stick. Can you appreciate? This is the hockey stick or doming of the mitral anterior leaflet. This is a huge RA. See how small the RV RA are. This is a huge LA. This is the mitral valve. This is an MR. This is not an MS. This is an MS, like a flame. It's like a flame shaped appearance of turbulence going from LA to LV. Treatment is in medical treatment is rate control with beta blockers, using of low dose diuretic to prevent pulmonary edema. Interventions are PTMC, that is percutaneous transluminal mitral commissurotomy or balloon mitral valvotomy, or surgical replacement. AF management has to be done with anticoagulation, no need of Chatzva score in valvular heart disease, and RHD prophylaxis. If MS is due to rheumatic heart disease, penicillin prophylaxis is warranted. I need all of you to go through the penicillin prophylaxis guidelines in different age groups. So this is a picture of the PTMC or balloon mitral valvotomy. This is the valve which has two portions, and it is a catheter used to put the valve inside the LV and brought back in the mitral valvular area and inflated to increase the mitral valve area. Some of the contraindications of PTMC we need to know. That is moderate to more MR, LA or LA clot, calcified commissures or mitral annular calcification, significant aortic or tricuspid disease, in which case you have to send the patient for surgery, open heart surgery, and Wilkins score has to be less than 8 to 9. Surgical replacement is done when PTMC is contraindicated. So this contraindication to PTMC is also a very common MCQ that comes, and in PACES stations also you might be asked about this. So I'll conclude my class at mitral stenosis. We will take up the other valvular diseases on second session, and I will also please go through the topics that we discussed today. I'll be also taking a small quiz in the next class. Is there any question? Should I continue, or I can see there are 9 people online. I can see there are 9 people online. So we are beyond our time, 5 minutes beyond our time. So I'll just end this session with a quiz. This is a recall quiz as we read about the congenital heart disease. So if a young adult develops cyanosis and clubbing after childhood history of a hole in the heart, this is how they come to the hospital complaining of a hole in the heart when they were a child. So what is the diagnosis of this patient? This adult, say 19, 20-year-old, has developed cyanosis and clubbing. What is the diagnosis? Yes, correct. Dr. Srinivas, right? Yeah, this is correct. It's an Eisenmenger syndrome because in all others, the cyanosis will have developed earlier, right? In tetralogy of Fowler, it develops by 6 months of age. TGA can have cyanosis from the birth. Pulmonary AVM will also have cyanosis from a younger age. Only in Eisenmenger's syndrome, after Eisenmengerization only, the cyanosis and clubbing will develop. So I'll end the session here. It was, I have left some 30 more slides. So I'll take those up in the next session. If you have any inputs in what would you like to learn in the next sessions, I am open for discussion. I was planning to do a bit of heart failure and cardiomyopathies in the next session as well, apart from the valvular heart disease. If you have any questions or elaborations, or if you will like me to teach any of the specific topics, you can write it down in the chat box. Yeah, so yeah, nobody has much of a suggestion. Yeah, so I'll continue with my planned course in the next session. It was great talking to all of you. I hope more participation in the next session. And I'm very glad that most of you answered and tried the questions. But I will be happier if you tell me what you want to know more. I mean to cover each and every topic that is asked in MRCP Part 1 and Part 2, so the sessions might be lengthy. Thank you. Thank you so much.